So, good morning, friends. So, today we will discuss about clubfoot. So, what is clubfoot and how it is managed? So, what is clubfoot? It is the commonest limb birth deformity. You can see the foot is like a hockey shaped. So, what do these people have in common? Like Mia Hamm, Troy Aikman, Christy Yamaguchi. See, they all are born with a clubfoot, but they are properly treated. And you can see here that baby, that girl also born with a clubfoot, but it is not treated and that it's a permanent deformity. So it's the most common birth deformity of lower limb. Approximately it's a 1.1 in every 1,000 in live birth. And you can see the foot is turned inward and downward. So you can see from hind foot, the heel is in varus and it is an equinus deformity. And you can see the forefoot, there is this adducted. Adducted, it means the foot is not aligned with leg. It is turned inside. The foot is in supination and there is a cavus. Cavus, you mean it is increased arch. The medial arch is increased, that is called cavus. So clubfoot, it's a mixture of cavus, empty adductors, heel varus and equinus. So it is a mixture of four deformity. It might be detected. It is not always, but it might be detected in ultrasonography at the pregnancy of 16 to 18 weeks. So why we are discussing about management of clubfoot? The reason is every 3 minutes, a child born with a clubfoot. It is very common. But the good thing is, if it is timely treated, it is nicely corrected. Why it should be treated? Yes, you can see it's a lot of physical disability. If baby is born with deformity and it will permanently stay, there is a lot of social stigma. If it permanently stay there are limited future of education, jobs, marriage. So it means in the society or in the family there are huge burden if it is untreated. So before 90s, treatment was difficult. Treatment was there for clubfoot. The modality was the multiple surgeries. Even though surgery was performed, after surgery there are huge scarring over the foot. You can see here the big scar. Big scar. When child grows, the deformity again recur. The foot become more rigid. That leads early arthritis. A lot of burden was there. Treatment was there, but the modality was different. And even though clubfoot patient was treated, there are many comorbidities. So this man came to Ponseti and he changed the concept of clubfoot. What is different? You can see here, he found that, or he identified that the abnormal tarsal correlation. It's a congenital dislocation or subluxation of this is a talus and this is a navicular. It's a talo-navicular subluxation or dislocation. And this is a primary pathology and all the secondary changes happen here, the tarsal bones and the soft tissue structures. And he found a technique that is called Ponseti technique. It's a newer modality how clubfoot should be treated. So in the Ponseti technique, there are two phases. One is a treatment phase, another is a maintenance phase. So what in a treatment phase? So what we do initially, we will examine the foot, we will manipulate the foot for 60 seconds. Then we apply plasters, approximately 5 to 6 plasters every weekly to correct cavus, adductus, and varus. Simultaneously, all the deformity will correct by only plasters. It's the last, once the foot is nicely supple, it will go outside. Then this residual deformity, residual equinus correction, that will be done by percutaneous heel cortinotomy. We'll explain in detail. So how will manipulate? So this is manipulation of the, suppose this is a case of foot. Give a manipulation, give a stretch of the deformity so that soft tissue gets stretched. So this is a first stage of your Ponseti technique. Manipulate the clubfoot. Now, This is a second stage. Before, so here is the difference. Identify the Talar head. How we can identify? So first you identify the fibular head and go proximal word, go anterior word, the first bony prominence. This is a Talar head. And this Talar head, it acts as a fulcrum and the correct, give a stretching, give a abductus, adductus should be corrected and apply cast. So how we will apply plaster? It's a snugly fitting soft roll. First you correct the correct the deformity, maintain the deformity, and then you apply soft roll, and this is a plaster. So plaster application, this is in real art. So where it's a snugly fit, there should be no pressure point and proper molding over the foot and the heel, that gives the best result of plaster. So once you correct the foot up to full abduction, you can say it's a 50 to 60 degree external rotations. And once it is corrected, then the final deformity, equinus, that should be corrected by tenotomy. So what here we can do, that is called percutaneous technique. There is no incision. We use just 18 gauge needle, identify the heel cord, give local anesthesia here, enter the needle here, and cut the tendon Achilles. Once you cut it and your last deformity is corrected, you can see here, you will achieve at least 20 to 30 degree dorsiflexion. And it's a just OPD procedure. After performing this procedure, apply the cast and you can send the patient home. There is no require for admissions. So once you finish the corrective phase, this we will enter in the second phase, that is called maintenance phase. After 3 weeks, we will remove the plaster and we will apply this DV splint. You can foot abduction. You can also say it's a foot abduction brace. So you have to, patient has to wear initially 3 to 6 months for at least 23 hours per a day, then 12 to 14 hours a day up to 3 to 4 years. So you can say it's a night. You have to give a night splint up to the age of 3 to 4 years. So let us understand by seeing a 1K. It's a 7-day young child, deformity of both feet. You can see here that both feet are deformed, both feet having a CTEV, congenital talipes equinovarus deformity, or you can say it's a clubfoot. The all 4 deformity mixture is there. There is a cavus is there. There is empty adductus is there. There is significant heel varus, and there is equinus. So how the baby is treated? There's a first cast, second cast, third cast, fourth cast. After fourth cast, we perform a tenotomy, and after tenotomy plaster removal, you can see the baby is absolutely fine. So this is a initial foot, and after 2 months, the foot is nicely supple, nicely corrected, or within a 2 months without putting any incision. So there are some beliefs regarding clubfoot. Do physiotherapy, it will help, or it will be done by only physiotherapy? No. So whenever there is a clubfoot, it will not correct by physiotherapy only. Another belief is there, wait and watch, we will treat after 4 to 5 years. No, within 4 to 5 years, foot becomes so rigid, it's very difficult to treat. Make some special shoes, it will correct its own. No, shoes is for correct. Once you correct, and to maintain that correction, shoes will help. Initially, shoes will not help. So some basics, never take it easy. Treatment should be started as early as possible. So ideally, it should be started from first week of birth, because in the first week of birth, baby's ligaments are so lax, so you can easily correct. Then follow the Ponseti principles and follow the post-corrective rules. So if you don't wear, or the poor compliance of foot abduction brace or splint is not properly weak, so there are high chance of recurrence of the deformity. So clubfoot, it is very easy to treat, but the only one liner message, it should be treated as early as possible by using the Ponseti principles. Thank you.